We're excited to start our event with Dr. Raju Hajela. Hopefully, I said their last name correctly, sir. Very excited for this event. It's going to be a little bit different today as we're going to have some interaction. So I have unmuted your mic. As people are coming in, I'm unmuting you, so you're allowed to talk during the presentation. If you have anything you just want to type in the chat or the Q&A, you can do so. A couple housekeeping things. We do offer CME CE credit for this event. You will have to stay for the entire event to claim that credit. You'll receive an email from SunCloud this afternoon. It will give you the instructions to go take the survey, a little short post test, the survey, and then you'll get your certificate as soon as you complete the survey. If you do have any questions, please reach out to me in the next slide. Sal, if you can click that over. My email is there. I'll also put my email in the chat so you can write that down as well. If you have any questions about the presentation or you have any problems whatsoever, please don't hesitate to reach out to me and I'll help you navigate through any complications you have. I'm going to introduce you to Dr. Kim Dennis. She is the owner-founder of SunCloud Health in Chicago, an amazing person to not only work with, but to get to know as a colleague. So I'll let you take it from here, Dr. Kim.
Thank you so much, Tammy and Sal, both for your footwork in making this happen today. Hi, everybody. I'm Dr. Kim. I am the co-founder, Chief Medical Officer, and CEO at SunCloud Health. We are a residential IOP PHP based treatment program in the Chicagoland area where we serve adults and adolescents. We have two residential units for adults, and then PHP IOP programs for adolescents and adults. And based on our latest research data, we have about 70% of our patients have some way, shape, or form of addiction. And our specialty is really treating people with complex comorbidity, psychiatric comorbidity, in addition to addiction, eating disorders, and almost universally trauma. We have a specialty residential unit specifically for people with eating disorders and comorbid addiction. And we also have an outpatient interventional psychiatry offering where we can provide TMS and esketamine to people inside and outside of our treatment programs. So without further ado, it's my honor to be able to introduce you all to Dr. Raju Hajela. Dr. Hajela is somebody that I've known in the addiction world for many, many, many years and really got the chance back in September to spend a little bit of time with Dr. Hajela at the International Society of Addiction Medicine. And my research team, who are also present here today as participants, got to watch your lecture there on borderline personality disorder. So let me tell you a little bit about Raju. He is a co-founder and principal of Health Upwardly Mobile, Inc. He received his MD from Dalhousie University in Halifax in 1982 and his Master of Public Health from the Harvard School of Public Health in 1988. He has practiced Transcendental Meditation, TM, since 1986 and completed his training in Maharishi Ayurveda in 1994. He has held leadership positions in provincial, national, and international medical organizations over his long career. He's developed and delivered many training programs for health professionals, and he has an extensive public record with many invited conference plenary presentations and workshops to his credit. He has received numerous honors and awards for his leadership and community work, and he has held faculty appointments at medical schools, including Queen's University in Ontario and the University of Calgary. He has often provided presentations for corporations, government, and the general public. He has been the lead developer of the Canadian Certification in Addiction Medicine established in 2000, and the internationally recognized definition of addiction established in 2011 through the American Society of Addiction Medicine, which, by the way, is the definition that we still go by at SunCloud Health. I'm sure part of what you'll hear about today is what's changed subsequent to 2011 with that definition. He is a founding and honorary life member of the Canadian Society of Addiction Medicine and a founding and life member of the International Society of Addiction Medicine. He is a diplomat of the American Board of Addiction Medicine. He is a certificate with added qualifications in addiction medicine and a fellow of the College of Family Physicians of Canada. He's a distinguished fellow of ASAM and ISAM. He's a member of Rotary International and the North American Leader board member for the Rotary Action Group Addiction Prevention. And he is the founding medical advisor to the Foundation of Addiction and Mental Health. So without further ado, I'm going to turn it over to Dr. Hajela. We will end promptly at 1:30 Eastern Standard Time, and we will have ample time for interaction and discussion. The more present people are, the better.
Thank you, Kim. It's a real honor and pleasure. When I hear this kind introduction, it reminds me that I'm getting old. I think as much as I've done so much, but I think the focus I've always kept is what am I doing today? So it's always a bit of a surprise to me when somebody recounts where I have been. So certainly the topic is defining addiction and mental health, but I think I will start from the perspective of talking about human behavior in general, because the subtitle for this talk is also From Spirituality to Behavior. And some of the things that I'm sure the audience is aware of, and Dr. Kim has hinted at, that there is that difference in perspective between psychiatry and addiction medicine. And that's a bit of a disclaimer for me, as much as I've had appointments in the departments of psychiatry at medical schools. I'm not a psychiatrist. So I'm one of those physicians who was very interested in mental health from medical school days and did not choose psychiatry because of its focus too much on behavior. Having said that, I did at one time join the Society of Behavioral Medicine in the US, thinking that that may be the key to having an interdisciplinary approach to treating addiction and mental health. But that was not to be. As I learned more and practiced more, I realized that behavior was a bit of a red herring. There's been a tendency in medicine to focus on behavior and behavior change, which is all very relevant and needed, but there is much more that is required in understanding where the behavior is coming from. So that's a bit of an overview of where today's presentation will be, and I hope there'll be a lot of interaction and lots of questions. I was talking to Tammy earlier, just before we got started, that if the audience is not going to ask me questions, I'll start asking questions of the audience, and hopefully that'll get the ball rolling. So speaking of behavior, I don't know what the audience experience has been in looking at human behavior, but I can share very briefly my experience with it. That when I started asking questions about human behavior in medical school back in 1978, when I got started in Halifax, the general answers were, are you trying to be a social worker or a psychologist, or are you a doctor? So I minded my P's and Q's, but and acted like a doctor in medical school to conform. But inwardly, I am a nonconformist, and I can tell you, I used to go to the library in those days before the internet and look up psychological journals and social work journals, because addiction problems tended to be discussed more in those journals than medical journals, which were more focused on complications. And certainly psychiatry at that time was transitioning from DSM-2 to DSM-3. And those of you who are familiar with the history may remember that up till DSM-2, most of psychiatric diagnoses were described and defined as a reaction to their people's environment. But starting in 1980 with DSM-3, all the classification system by the American Psychiatry Association and American Psychological Association, it changed to behavior-based diagnoses. So that's where 3, 4, and 5 have gone on to be very much entrenched in behavior and behavior change. And ironically, as much as the DSM system was invented to bring some clarity, the DSM system, in my opinion, has actually created more confusion, because the DSM diagnoses, even though they are behaviorally defined and described, they are not discrete. So the joke in the mental health field, in psychiatry, even among psychiatrists, often is that the diagnosis really depends on where the psychiatrist is coming from rather than where the patient is coming from. And in some ways, that actually is connected to a very old spiritual adage that some of you may have heard before, which says that we don't see the world as it is. We see the world as we are. And what that says is that we all have our own filters and biases that are built up based on how open we are or how closed we are, what our exposure has been over our lifetime. And we tend to see the world through that lens. So it becomes really challenging to have some sort of a framework, but then in some ways, as care providers, we have to suspend that lens and then try and see the person as they are. And certainly I can speak for myself. That's where I started back in medical school. And when medical school wasn't giving me many answers beyond just the complications related to psychiatric and medical problems, that I started to look at broader issues. And it was really during my Master of Public Health year at Harvard, that was 87, 88, that I came across behavior theories that I became more familiar with. And that's where I'd like to start, to just give you a sense of a very simple framework to look at as to what drives human behavior. And certainly there are many, many theories around, but I'd like to highlight 3 main ones that have been the mainstay over the decades. The first one that probably most people are familiar with is technically called theory of reasoned action. And that basically posits that people have a way of thinking or have some thoughts, and then that leads to behavior. And if you look at that as a basic theory, you'll see that cognitive behavioral therapy is an offshoot of that theory. And it's not a wrong theory, but it gives so much importance to thinking that it totally discounts that a lot of our behavior is quite automatic. So as much as we think and then do something, but oftentimes we do something and think about it afterwards. And in many ways, we make up a story about our behavior after we've done something, rather than proactively decide that, yes, this is the direction I'm going to go in. So it's a bit of an anomaly that exists for all of us. Having said that, as we become more enlightened and more focused and more, what would be, perhaps it's hard to describe, but more spiritually grounded in terms of our values, then our behavior becomes a little bit more consistent. And certainly this is a point I'll come back to when we're talking about recovery, that in recovery, that's where people make progress, and there's a lot of personal growth that happens. So the theory of reasoned action focuses on the thinking, but there's much more that drives behavior. Now, there's also another theory that has been around forever, which is called the health belief model. And certainly from a medical perspective, there's a lot written on that people will act a particular way based on whatever their beliefs are about their health, and they will try and make decisions consistent with improving health. Again, makes perfect sense. And it's valid too. And certainly in today's world where there's so much information available, but there's a lot of misinformation. So people are left in a quandary as to what is healthy for them and what is not. And even when they buy into something that is healthy for them, they're not often able to follow through. So health belief model also goes a little bit beyond thinking, focuses on beliefs, but it's still a very thinking-based approach. And there is that idea that we all are rational creatures and we will do things in our best interest. Reality is that none of us always do things that are in our best interest. We are driven by many other forces, largely social forces, and of course, political forces influence us as well. And things happen more with that momentum that is all around us and within us, rather than in a steady, healthier manner that would be best. Certainly, apart from these two theories, the other behavior theory that gained ground in the 70s, there's even a very important, influential name attached to it, is a father of social learning theory who was known as Al Bandura. And I didn't have an opportunity to meet Al Bandura personally, but I did have a lot of contact with colleagues who had worked and trained with him. And social learning theory basically says that all human behavior is guided by whatever is happening socially and in that socio-cultural context. And that theory is dominant in the social work world, but also in the psychology world. Certainly in the psychiatry world, it's talked about biopsychosocial model of psychiatry as was defined by Dr. Engel many decades ago, gave importance to social aspects of behavior. In India, where I spent just 6 weeks this fall, the idea of social psychiatry is very big there, to really look at social influences. And that all is also correct. But I'm using the word also a lot because many of these things take human behavior and try and put it through a particular lens. And in my opinion, miss out on the broader aspects. And the broader aspects that I would say that people are hesitant to talk about are things like spirituality and things like feelings. Because we live in a society where dominance is towards thinking and producing, whereas feelings are a little bit messy and harder to define, and spirituality perhaps even more so, especially as over the last several centuries, spirituality and religion have become conflated. Now, again, a personal bias. I grew up in India for the first 15 years of my life. So I can say that when somebody asks me what my religion is, I can check off the box for Hindu. But I hope you'll consider that even the term religion and Hindu is a projection from the Western lens. Because in India, as I grew up, and even the country India, I didn't grow up knowing it as India. I knew Bharat, which is the local Indian name for that. But India is one of those names that was given by the West to that part of South Asia. And it seems to have stuck such that Indians call themselves Indians, and indigenous people in North America are still called Indians, despite the fact that Christopher Columbus made that mistake of thinking that when he arrived in this part of the world, that he had arrived in India. Now, having said all of that, I raise that point to say that even such a thing as Hinduism that people take for granted, technically speaking, there is no such thing as Hinduism. And the word that I grew up with, that actually the West is becoming more familiar with, is called dharma, or in the Western way of saying it, people call it dharma. And that word, a Sanskrit Hindi word, dharma, basically translates as duty or purpose. And in the Ved, which is the ancient body of knowledge that is in us and all around us, and Ayurveda that Dr. Kim mentioned in my introduction that I've had training in going back to more than 30 years, is the medical part of the Ved. And in that treatise called the Ved, or knowledge, it says it is the duty of every human being to discover what their own dharma is, their own purpose, their own consistency there with their value system, rather than following somebody else's. So I hope that gives you a sense that this idea to be independent is something that is inherent in a way of living in the part of the world that I come from. Yet, in most parts of the world, including where I come from, there's been this social force for conformity, for everybody to belong to a group, belong to a religion, and belong to a socio-political party. And in all of that, I hope you will consider that spirituality gets distorted, because there's an inherent conflict that starts between whatever I believe and I think and I feel and what is going on around me. To the extent that also happens within families. And certainly growing up in India, extended family systems, there was a fair amount of consistency. But certainly coming to North America in my teen years, discovering how life was here, the inconsistencies become even more pronounced, where often parents and authority figures will say, do as I say, rather than doing what I do. And that kind of conflict then arises in each individual to say, I feel one thing, but I'm being told to do something else. I see one thing, but I'm being told otherwise, and then I'm asked to conform. So these are all basic issues that I hope you'll keep in mind as we talk about human behavior. And I think my fundamental trust in talking about all of this is to help you consider that a fair amount of behavior that we engage in day to day is automatic. So it becomes very important within us and around us, and especially when we're trying to help people, is to look at where they're coming from. And that's where certainly in my practice and now within Health Upwardly Mobile, or HUM, as we call it, and if you're interested in finding out more, you can Google my name and you'll find the Health Upwardly Mobile website, or you can go directly to healthupwardlymobile.net to our website, and you'll see what our approach is in terms of doing comprehensive assessment, where we evaluate a person on all four dimensions, which are biological, psychological, social, and spiritual. And even within that, we start out with a standard nursing assessment, which is collecting a lot of information. Nurses are trained in gathering that information, and generally patients are very open in a medical setting to go through that evaluation. And then we do a second level psychosocial evaluation. And within that is some degree of spiritual evaluation. And then they come and see me, a physician, and any other physicians that may be part of the team. So then we do a combination of weaving everything together as biopsychosocial spiritual. And then we aim to provide care consistent with wherever the patient is at. And where the patient is at then has to be tempered by what our assessment is. Now, our tendency is not to use the DSM framework for diagnosis, and I can go into reasons for doing that in more depth later. I've hinted at some reasons already because of the behavioral perspective and just the DSM adherence just to the behavioral model. And if we come from the biological aspects of how our brain operates, then we get into the definition of addiction. And maybe at this point, I'd like to just ask the audience if there are any questions about what I've said so far before I shift gears and go in another direction. I'm not able to see any of you. I see that there are 39 participants, and I see that there's something happening at the chat.
Yeah, just to let everybody know that I have unmuted everybody's mic, so you just have to unmute. And also I have made everybody panelists so they can turn on their cameras if they have them available to them, so that way you can see them.
And I also see there's a raise hand button, so please, I'll give you a few seconds and I'll take a drink of water if there are any questions or comments so far.
So I have one while we're waiting for others. Can you say a little bit more about the difference between religion and spirituality? Because oftentimes in talking to patients, there is a pretty profound resistance to any questions about spirituality because it's often conflated with
Mhm.
religion.
And that's exactly the point. And I can make more explicit that religions around the world have developed a lot of dogma. So there's a lot of expectation of conformity that people rebel against. And especially if I belong to a religion or a church system where I may have sustained a lot of trauma. Now, Catholic Church is one example that is pretty evident to everyone, especially in today's day and age of information sharing on the internet. So we see a lot of patients who carry a lot of trauma related to their Catholic upbringing, for example, or whatever they went through the church. And fundamentally, what we try and say to patients is the way we talk about spirituality is from a very personal perspective. That's why I shared the example of the Ved. In the Ved, it clearly says that it is important to discover one's own dharma and follow that, which is much more individualistic than conforming to a religion. So, from that perspective, those of you who are familiar with what is called Hinduism, and when the Western contact happened with Bharat, there was a tendency to say, well, there are many gods in India, and you can follow whichever god you want. When in reality, when you look at what it is it's actually freedom of spirituality. And plus, there's a common language where you can look at various deities in terms of what their role, function, and connection is to humanity, that people can align themselves to that. So that is a way that I would suggest to talk to people, is to leave religion aside. And even people who present to us as being very religious, because we have that clientele as well, we still ask them as to what that means to you personally. And if we look at the example of Alcoholics Anonymous, as much as AA came to be in the US, and a lot of people still say that AA is a religious organization, it has Christian roots. But if you actually look at what AA is and how it was formed, it is actually quite anti-religious. So AA is very spiritual, but it is anti-religious from the perspective, it says this idea, it promotes this idea that you connect with God as you understand him or her or it, or don't. So sometimes people joke about it saying, well, anything can be anyone's higher power or anything can be God. And AA has no opinion on it, but by the same token, AA members often say, and I've had patients over the years say, for them, God is good orderly direction, or God is great outdoors. Or I have had patients say in step 3 that I'm willing to turn my will and life over to God as I don't understand him, her, or it. So in that sense, as I've been making the pitch, in order to connect with spirituality, we have to go beyond thinking, and in that sense, connect with feelings more. And I could actually give a whole talk, if time allowed, on how, from a physics perspective, everything starts from consciousness, from spirituality, and then feelings are the intermediary variable that then lead to thinking. So, which is directly opposite to the two behavior theories that I shared with you, the theory of reasoned action, that thinking is dominant, or even the health belief model, that belief has to be translated in thinking for behavior. And again, it's not wrong, but feelings and spirituality precede the thinking.
Any other questions from the audience before Dr. Hajela goes on? Looks like no.
All right. I'll come back to the stream that I was going to turn to. So again, speaking very personally, when I was in medical school and talking to people with mental health problems and listening to them, the usual diagnoses are depression and anxiety. And psychiatrists were trying to tell me all kinds of theories about depression and anxiety, and the transition from DSM-2 to DSM-3 was formalizing depressive disorders and anxiety disorders and the idea of bipolar disorder as a sort of much more definitive thing, as opposed to manic depressive illness, as we used to call it back then, was all coming to be. But when I talked to actual patients and took their histories, I actually heard a lot of alcohol-related problems. This was in Halifax. Drugs weren't as dominant in that culture at that time, although things have changed dramatically there too. And there were a lot of sociocultural problems, because Canada also, like the US, has people from different cultures around the world. And there were a lot of adjustment problems. There were a lot of problems with rural isolation. There was a fair amount of trauma, sexual abuse, emotional abuse, physical abuse, spousal abuse. So there were a whole host of psychosocial factors that psychiatrists weren't even asking. As any naive young medical student, I had time on my hands, so I would get all of this. And certainly patients always talked about addiction. And back then, even clinicians talked about addiction, but there was a push in psychiatry and in medicine not to use the term addiction. And the term that was being encouraged and is still the word that exists in the International Classification of Diseases, and that word is dependence. So back then in DSM-3, which was carried on to DSM-4, but not to DSM-5, that there were two substance use disorders defined, one called substance abuse and the other one called substance dependence. And substance dependence was, and internationally is still, considered analogous to addiction, whereas substance abuse is not. Now, having said that, in common language, even among psychiatrists and physicians, substance abuse has always had more traction, despite the fact a couple of decades ago, and the World Health Organization said it, the American Society of Addiction Medicine said it, the Canadian Society of Addiction Medicine said it, that we don't want to use the term substance abuse, but it was still part of the DSM lexicon. So we tended to explain substance abuse in terms of what the World Health Organization had proposed, that let's call it hazardous use if it's episodic, or harmful use if it's more regular. But we have to call those, whatever problems they are, hazardous use or harmful use, if we've ruled out substance dependence. And those of you who are familiar with DSM-3 and DSM-4 may remember that the instructions were that if you see someone with substance-related problems, you have to do an assessment to rule out dependence, meaning you start with the assumption to say, this likely is dependence, and if the criteria are not met, and there were 7 criteria historically, and someone had to meet 3 out of the 7 to qualify for the substance dependence diagnoses. And if that was met, then you treated substance dependence. If that was not met, then people were given some education, and still longitudinal follow-up was recommended, because sometimes if the problems aren't openly acknowledged, then they may turn up later. And this is something I'll come back to when we talk about the natural history of addiction and the progressive nature of the disease, that earlier presentation can often be missed, especially in our society where getting drunk or using drugs is considered a growing up ritual, or in various jurisdictions now in Canada, all across Canada, cannabis has become legal, but there's a tendency to downplay the harms related to substance use. So these are all issues that conflict the diagnostic systems, and also makes it difficult for people to stick to what is being proposed technically. So hazardous use, harmful use, dependence as the framework internationally in the International Classification of Diseases. In these DSM, the framework persisted until 2013 as substance abuse and substance dependence. And unfortunately, with that decision in DSM to go to substance use disorder, a lot was lost, because the one distinction apart from the criteria was that substance dependence was and is characterized by impaired control over behavior. So that's one of the C's of addiction that many people in the audience may know of, impaired control. We used to say loss of control back then, but impaired control was a better term that has gained traction, and it is the preferred and consistent term. That impaired control defines dependence, and that's where neurobiology helped us out, because all the neuroscientific research through the 90s and brain imaging and benchside research, and especially two neurobiologists, Dr. Elliot Gardner and Dr. George Koob, who are both still around, although elderly, but still doing great work and giving talks. So if you have an opportunity to hear them, you can hear the history in terms of how neurobiology helped define what characterizes this impaired control. And certainly in ASAM, when we developed the definition, that is the standard since 2011, that idea of impaired control was incorporated in the criteria. So that is impaired control over behavior is what we call the B of the disease, that I'll talk about it a little bit later. Now, when DSM-5 combined everything as substance use disorder, unfortunately, rather than moving forward, things fell back to substance abuse, such that that idea that impaired control is something important has become watered down. And this question will come up later. I might as well address it just briefly here, that as Dr. Kim mentioned initially, that the 2011 definition remains the standard because it is neuroscientific. But in 2019, ASAM made a political decision to try and give a watered down definition, which is more in line with DSM-5. And unfortunately, it's more in line with substance abuse, because the second C, which is perhaps even more well known than the first C, which in a lot of platforms, even amongst non-medical care providers, the idea that addiction is just continued use despite negative consequences, that's another C, is actually the definition of substance abuse. It's not substance dependence, it's not addiction. So in the 2019 definition, ASAM did include compulsion as a C. So compulsion and continued use to try and define, no, this is addiction because the person has some degree of compulsion. Although we know a lot about what constitutes compulsion or just impulsive behavior in the brain, but the ASAM definition didn't really address that. It's the 2019 one. Now, if we go back to 2011, and in that sense, the DSM-5 did carry the criteria of craving through. So in the 2011 definition of addiction, we have craving as the C of the disease. And craving is one of the 11 criteria as a checklist for DSM-5. But because it is all called substance use disorder, and because it's a clinical decision to classify it as mild, moderate, or severe, it really makes it very difficult to look at what the person needs and how the treatment needs to be tailored, because people are constantly looking for, okay, what is the standard treatment for substance use disorder? And even there, what is the standard treatment for opioid use disorder or alcohol use disorder or cocaine use disorder, rather than looking at what's happening in the brain and what is the unifying characteristic. So I can bring you back to the 90s again and say emphatically and vehemently that in Canada, we were a little bit ahead of the curve, because even though I was a member of ASAM, but Canada being smaller group of colleagues, we were able to come to a consensus to define addiction as a primary chronic disease characterized by impaired control over the use of substances and or other behaviors in 1999. So in Canada, we chose that C, impaired control, as a defining characteristic to highlight that substance dependence and addiction were the same thing, although addiction is much more than just substance dependence, but substance abuse was not. So I hope the audience can keep that in mind as I'm sharing more stuff. And when we are in the discussion part, we'll have a chance to talk more about that. So coming back to the definition and how the definition in ASAM came to be, or even a step before, this is a question that I often get asked, and it's a question I had in my mind early on, that is addiction a lack of knowledge? And if people are given enough knowledge and wherewithal, then they will do the right thing? Or it is this impaired control? And I would say to you that yes, the lack of knowledge is there, no doubt, but the impaired control is much bigger factor. Because as much as we say denial is a big part of this disease, where people are stuck in their own way of thinking, they're not open to learning about anything else. But what I have found is that people do know, but if they acknowledge something, then the onus falls on them to do something about it. So a lot of denial that we say is the person not paying attention is actually the patient's unwillingness or trusting that something can be done which will be different. So this is a practice point that we can come back to, and I hope people will share their own experiences as to how to address that. Certainly in behavior terms, we call that the difference between pre-contemplation and contemplation and preparation, then on to action. So we can talk about this in that framework too. But coming back to the definition, when we were gathering together the forces with what the neuroscientific research was saying, a lot of us were concerned where DSM was headed, because between DSM-4 and DSM-5, there was a lot of discussion going on. And Dr. Chuck O'Brien, a very well-known psychiatrist in the US, who did consult us in the American Society of Addiction Medicine, we were abreast of what was being proposed. And despite our best efforts, it wasn't happening, which gave us a little bit more impetus in ASAM starting in about 2007 to get our act together and come up with a definition. So the definition, as we were able to come up with as a consensus with a wide circulation and then discussion. So the definition as we see it as 2011 was actually finalized by 2009, but we took the next 2 years to really polish it. And the definition, if you haven't seen it, I'll just tell you about it in 3 sentences, because the first paragraph of the short definition is just 3 sentences. And it starts with the base as we had developed in Canada in 1999, that addiction is a primary chronic disease. So the idea that it's a primary disease, that all the theories that are out there as to what causes addiction, they are not necessarily valid. So we talk about trauma as an aggravating factor rather than a causal factor as it is talked about. So highlighting it as a primary disease gives it a little bit more status, that it needs to be treated as an entity of its own. Because in psychiatry, and certainly in my training in years gone by, and that idea still I found persisting, is that people engage in addictive behaviors or the use of substances because they have underlying problems. To the extent I still encounter patients who've been told by the family doctor that if they take their antidepressants, then they wouldn't need to drink or smoke marijuana as much. Totally false, but unfortunately that's a sociological idea that does persist. So that was the thought behind highlighting. The evidence is all there, that it's a primary disease and a chronic disease. And it is a primary chronic disease of brain reward, motivation, memory, and related circuitry. So we wanted to establish the biological base that defines the impaired control. And it's in the second sentence that we said dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. So giving people a lot of latitude there to do a more detailed evaluation to see what exists. Certainly on the biological level, there are issues with what's happening in the brain, but exercise factors, nutrition, all of those come into play biologically, psychologically, thinking and feeling factors, socially, goes without saying, whatever people have been exposed to. And certainly there, trauma is a huge aggravating factor. And there's a tendency for people when they are talking about their problems related to addiction, they tend to focus on a discrete traumatic event, or a clinician will focus on that. And say, okay, so that is the reason addiction happened. Whereas what we have tried to convey through the definition, and what I do in my day-to-day practice, is that that's when addiction became worse. It became more manifest. And certainly I can say to you with confidence that as patients get into recovery, they start to understand that part. And then they start to see that the antecedents before a particular event that they had downplayed has much more relevance. And especially that's where the genetics comes in again, and the biological factors as to how they impact the psychosocial factors. Now, the spiritual factors, as we have touched on already, relate to values. But one thing that I want to emphasize at this stage, as we talked about, and it's described to some extent in the long definition of the 2011 ASAM definition, and that is still available on the website. You have to look for it a little bit, but it is there, and that's where we describe that the spiritual dysfunction related to addiction is the disconnection. Although again, internet being the internet, I'm sure you've come across the idea, some people say addiction is very simply a loss of connection, and then very simply often people say love is the solution to that reestablishment of the connection, and then all will be okay. And again, people are not wrong, but unfortunately a lot more is needed to address the biopsychosocial spiritual issues rather than just say love is the answer. So that was the second sentence. The third sentence is what addresses behavior, and the third sentence says this is reflected in a person pathologically pursuing reward and or relief with the use of substances and other behaviors. The relevant factors here are psychologists in the audience will recognize the idea of positive reinforcement, which is reward, and negative reinforcement, which is the idea of seeking relief, that those two things are central. And we often say, and this is, I mentioned Dr. Gardner and Dr. Koob, Dr. Gardner's work is more on the reward side, which is positive reinforcement of drug use. And Dr. Koob's work is a lot on seeking relief. So that if you want detailed information about those two things, then you can follow that or explore more of those things in the works of those two scientists and many more who have followed those lines of thought. Now, coming back to that third sentence, hopefully you can see, and it's something that we have said very publicly, you may have heard it before, that behavior is a consequence of the disease. It is not the disease, and it is not the cause of the disease. And that's where there's a clear distinction from DSM, because DSM says behavior is the disorder. And then we get into semantics, people call it, although there is a very clear distinction. Psychiatry, APA, DSM did not choose the word disorder by accident. They actually knew and still know that disorder does not relate directly to any neurobiology. And many disorders have the same neurobiology. So it becomes, again, what I said, that in DSM and psychiatric diagnoses, according to DSM, it is more dependent on where the psychiatrist is coming from rather than what is happening with the patient. And because addiction is such a central problem in circles that don't use the term psychiatry, in Canada, certainly we use the term addiction and mental health much more commonly, to the extent that the biggest psychiatric hospital in Canada, in Toronto, is known as the Center for Addiction and Mental Health. Although it was a bit of a political decision back in the 90s to make that happen, but it does reflect a central point that most mental health problems, and we have neuroscientific evidence to prove that are related to addiction. So rather than depression and anxiety leading to the addiction problems, what we tend to emphasize is, based on the definition and other issues, that addiction causes a lot of mental health problems. So depression and anxiety, certainly in my practice for decades now, we talk about them in context of complications of intoxication and withdrawal. And I'd be interested in the audience's experience with this if you've had those kind of conversations with patients, but certainly I can tell you case history after case history, where people, when they understand what addiction really is, then they recognize how addiction actually preceded whatever other symptoms and problems they may have. So I hope that makes sense to you. And maybe I'll take a bit of a break as my coughing and my dry throat is increasing. and see if there are any points that people would like to raise.
Yeah, I found that really interesting as I sit and think of clients that I've worked with, especially some of my male clients who have who struggle with addiction and have pretty significant childhood trauma. And you see that when you start doing really in-depth case study of them, you start to recognize the addiction was the first thing that manifested as behavioral problems. I mean, you might have seen some things, school defiance, that kind of stuff ahead of that. But the minute they hit a certain age, you started to see this one particular case, selling mollies and other drugs in school, growing marijuana in his grandmother's greenhouse. This is all started around the age of 14, but had a very significant sexual abuse history in the family. So could you speak more to those manifesting behaviors?
Absolutely. And I think the point I would like to start with, perhaps, since you bring up the adverse childhood events idea, that in California, Kaiser Permanente has a huge database, and Dr. Vincent Limetti, some of you may know that name. He was the PI to really conduct this research to look at adverse childhood events and the impact of them, not only mental health problems, but physical health problems. So that link is really there. But if you actually look at the adverse childhood events questionnaire, it is all linked to addiction. Like even the trauma, sexual, emotional, physical, whatever it may be, it often is in the context of the adults around that child having addiction-related problems. To the extent that the 10 questions that are in the ACE questionnaire, once you look at them, they are all related to addiction. So saying, when someone says that ACE causes addiction, is like saying addiction causes addiction. Now, having said that, if we look at the genetics and in the environment as to what plays out, there have been very old studies that say that genetics trumps environment, meaning children genetically who carry problems related to addiction and they are raised in an environment where there's a lot of addiction, that's a no-brainer. But children who have the genetics, and even with the best of environment, they start to show those addictive behaviors very, very early. To the extent that we all know, and as children, we may remember even engaging in fantasy and telling stories. But I can tell you for a fact, and this is where talking to patients who have children, and even we can parse out where the genetic lottery was heavier towards addiction in one child and not as heavy in another child, is children with addiction tell more lies and more tall stories. Children with addiction often have expressions of shame that often shows up as anxiety, having low self-esteem, or not really being able to engage consistently in whatever is going on around them, and getting frustrated easily. So these are all behaviors that start showing up very, very early. From a psychiatric diagnosis perspective, actually, these are the children that get diagnosed with one of the first psychiatric diagnoses is oppositional defiant disorder, so ODD. And then often they'll get a label of conduct disorder, where there's a lot of behavior that is becoming, in some ways, antisocial. An antisocial personality disorder is an adult diagnosis, but in children, the diagnosis is often conduct disorder. And of course, these days, ADD and ADHD has become very fashionable. So a lot of children will get labeled as that and then get put on amphetamines. And interestingly enough, historically speaking, when I take you back to the 70s and 80s and even until the 90s, ADHD was considered a developmental disorder that kids grew out of. And even the earliest research on ADHD, when I tried to look into it as to who were these kids, what was their genetic history, and lo and behold, most of the research subjects were adult children of alcoholics. So these clues are all there in front of us. The question is, are we willing to connect the dots? And of course, in the last 20 years or so, ADHD has become an adult diagnosis, and the prescriptions of amphetamines have multiplied thousandfold. And that is a real crisis situation where a lot of people get other psychiatric diagnoses, and especially in the US, and get medicated and are put in that framework of symptom suppression and go on to produce, go on to perform, rather than looking at what has really happened, what is happening, and what the antecedent factors are. And my last comment about the trauma connection is, and the audience may be familiar with this, that if one goes to trauma treatment and doesn't have an idea that there's an underlying addiction problem or addiction needs to be addressed, then addiction actually gets worse. Because when you start exposing stuff that is hidden, then the only thing that the brain can do and where the person can go is to go seek some relief. So what we tend to do is we get all the information, and historically we have used the term called containment therapy, where we identify the trauma and say, yes, we know it is there, but let's build a framework of recovery. And that's the last part of my presentation. So I was going to turn to that and maybe stop here. And if there are any other questions, then answer those. And then we'll turn to what does treatment and recovery look like.
Yeah, and just to confirm that with everything you're saying, it just totally lines up with that specific client. Definitely family history of addiction. So yeah, really interesting stuff. Thanks for commenting on that.
And I just have one comment on the primary brain disease language in the 2011. Oftentimes at least in the US these days, as an addiction psychiatrist and as a person running a treatment center that specializes in comorbidity, oftentimes I'm asked, well, what's primary? And the answer is, well, these three things are primary, right? Like addiction is primary, complex PTSD is primary, and depression is primary. So it's not uncommon that I say to the doctor from the insurance company, which one would you like to pick as primary because this person has three. I think what's kind of been lost in American psychiatry is the very definition of a comorbidity is multiple primary illnesses happening in the same individual at the same time. Right. So
insurance and funding issues. So it's sad. In Canada, we are a little luckier because our billing systems for doctors are fee code based, which are whatever service is delivered rather than based on diagnosis. So, but that is a real problem. Any other points? All right, so I'll start the conversation about treatment and recovery from the second paragraph of the definition, which addresses the A, B, C, D, E. So I mentioned the B, which is the impairment in behavioral control. C is craving, but A simply says inability to consistently abstain. So that's just the behavior feature that people can see, and it's a point of engagement. Although I can say to you, I've had many patients over the years and continue to, who will deny A, who will deny B, who will deny C, but then when we start talking about diminished recognition of problems in one's behavior and interpersonal relationships, so that's the D, diminished recognition, they start to say, yeah, people tell me some things that I think they have some validity, but I can't quite see it. Or the E, which is the dysfunctional emotional response. And of course, it's very complicated, but the simplest expression of a dysfunctional emotional response is that a person will be cool with something that an average person would be quite upset over, or get upset over something that is very minor. So in that sense, we often talk about the pressure cooker effect and denial effects that people with this disease live with. And those are points of engagement sometimes. Then we can go back and then see where A, B, and C are operative. So from a treatment perspective, we help people simultaneously on A, B, C, D, and E. So for craving, certainly we talk about cue-induced factors and get people to look at naltrexone as perhaps an anti-craving intervention. Acamprosate is also available, although studies on that, my clinical experience on that is not that great, but it is a treatment option. And for consistently abstaining, we encourage that one day at a time. And we try and incorporate harm reduction as part of treatment as opposed to an option. Because if you truly understand the addiction and neurobiology, then you recognize that harm reduction is necessary to decrease harm, but harm reduction as a strategy for treatment long term just doesn't work. So certainly over the years, we've tried to develop systems where harm reduction is more an outreach strategy, but sociologically speaking, that schism still exists. So we try and help people consistently abstain from a treatment and recovery perspective, identify all the areas of impaired behavioral control. So try and establish some degree of awareness and action. We tend to discourage the term control, like we don't talk about reestablishing control, because invariably when people get into that framework, that mind frame, then the disease takes over again. So it's more a matter of monitoring to see, in the context of the Serenity Prayer, which simply says that I have to accept the things I cannot change and then put my energy into changing the things that I can. And then the wisdom to know the difference, of course, is to try and evaluate it myself, but then also realize that all of us, whether we have addiction or not, need outside feedback to be able to discern between what is within my domain to be able to change and what I just need to leave alone for now. And we do a lot of emphasis on for now, because life changes, circumstances change, and people may approach the same issue differently in time to come. And the D and the E is what we address through individual and group psychotherapy. That's where peer support comes in. And I am a very strong proponent, and that's what HUM is built upon. And that's what I try and teach and encourage, is to treat people in that chronic disease framework and provide longitudinal care. And as Dr. Kim highlighted, that if there's a primary disease of addiction, there's a primary disorder of CPTSD, there's a primary depressive disorder, these things are so entrenched that even if one can say, okay, yes, they are interlinked, but all three require longitudinal care and longitudinal treatment. And that's where, as much as I was saying that psychotropics can be a challenge in terms of overprescription can cause numbing, but if there are other complex issues going on like CPTSD or severe depression, then of course medication management becomes of paramount importance. And it becomes tricky as to how we are going to work with the patient. And that's where, again, to make my life easier, what has worked for me and what I recommend is complete transparency. So when somebody asks me, so doctor, do you think I'm serotonin deficient and do I need SSRIs? And the first thing that I discuss with them as to what SSRIs are, because this is another sad comment on our system where drug companies have been allowed to beat that drum that somehow SSRIs give you more serotonin, that even our colleagues have bought into. Because when you look at the mechanism of action, serotonin reuptake inhibitors basically leave more serotonin in the synapses. So unlike cocaine, where you get increased transmission, acutely with SSRIs, you don't even get increased transmission. Rather, this idea that SSRIs take a few weeks to work is because it takes a few weeks to clog up the circuits, which may be needed therapeutically, but then long-term, that is not an option. And in many of these patients, technically, we can't quite measure it, but just from a theoretical perspective, you can see that leaving serotonin in the synapses that clogs up the circuits, then blocks the reuptake, it decreases the actual amount of serotonin that we need. We also don't have technology advanced enough to really see what the actual serotonin levels are and where they are and how our body needs them. So that's where, again, we turn to general nutrition and those factors to try and encourage people to eat healthy, exercise, meditate, to try and develop a recovery lifestyle. Because if that is not done, and in the second paragraph of the definition, we have highlighted that being a chronic disease, it is a progressive disease like any other. So treatment has to keep up with the disease progression. It's not that once the disease is treated, then you're off the races. And if you have a relapse or some flare up, that you go back to where you were. And certainly Alcoholics Anonymous and Narcotics Anonymous recognize that empirically, which is where many of you may have heard that admonition that jails, institutions, or death are the outcome of this disease of addiction. And we've tried to highlight that even in the definition to say by treatment, we're trying to prevent premature death, disability, and highlight recovery as an avenue for growth and trying to keep one step ahead of the progressive disease. But finally, I'd like to make a comment on that we talk about the idea of freedom and personal growth, which goes beyond just treating the disease. To the extent that I've presented on this idea, some of you may have heard of it, although it's not been written up very much. It's the idea of negative liberty. Like initially, people get relief and release from whatever was bogging them down. So that is important in addiction treatment. But then we encourage positive liberty, meaning people have the freedom to do many more things. So in group psychotherapy, these are common issues that come up, that what am I getting freedom from now? What is bogging me down before? It's not anymore because I have a recovery focus. But then also look at what makes life fun. What do I have freedom to do to enhance my well-being and reach to my optimum level? So that's about all I had. And there is much more, of course. And as I've hinted at, I could reframe all of this in Ayurvedic terms, but I don't want to go there because it is 5 after 11 by my clock and 5 after 1 for some of you and 5 after noon for others of you. And we want to stop in 25 minutes. So back over to the audience now, please.
So if anybody has questions, please feel free to raise your hand in the Zoom room or even throw it in the chat. If you don't want to speak, I'm happy to say it for you. One question I have, Raju, is going back to the 2011 definition that talks about characteristics, spiritual manifestations of the disease. What would you say are some of those characteristic, observable spiritual manifestations? Because I think most people think of spirituality as being sort of an inside, internal thing that's kind of separate from a person's practical life.
Mm-hmm.
And when we think in recovery terms, I think a practical spirituality that becomes visible in a person's life is sort of what we are shooting for.
Yeah, the irony I would say is that people don't recognize that just that idea that spirituality is something all internal and I have to live my life on whichever way life is taking me is a bit of a disconnect, because spirituality is what defines us. So in some ways, when people say to me, I'm not spiritual at all because I'm not religious, because I'm an atheist, I usually counter that by saying, so atheism is your belief system then. So tell me more about that, because that is the value that is driving your life. So it is that what we have tried to capture in the long definition is a person's relationship with themselves and the rest of the universe. So the idea of God, we did address it, but as more an example rather than making God a central feature. Now, certainly in 12-step circles, the term God is used because the framework goes back to the 1930s. So we have to look at what sociological forces were in play then in America, especially those sociological forces still have a very strong force behind them. But we can reframe God as good orderly direction, great outdoors. And that's the way I try and engage people is, who are you? What defines you? And once I start asking those questions, people start talking. And certainly it takes repeated appointments and in that sense, not just individual I found that in group psychotherapy, it makes a huge difference. Like one simple transformation I can share from years ago, which was just so amazing, was someone who was so entrenched in, he didn't believe in a higher power or any spirituality because he grew up in an alcoholic home and he was regularly beaten, such that he ran away from home at age 15 and got into construction work. But of course, the disease continued. He never used alcohol, but he got into repeated accidents and repeated injuries, such that he ended up on opioids. And when he came to see me at age 21, he was really in trouble with opioids. But later on, as he got off the opioids too and got stable in recovery, one day he was just crying uncontrollably in group because he came to appreciate, as he shared, that if there was no higher power, he would not be alive. Because the number of beatings that he had had and how severe they were, and then the construction work, high risk activities that he had engaged in, he would have been dead many times over. So just that idea as to what is salient in your life, what is it, even in the most depressed person, I've had those conversations, what is it that'll keep you going? Like one of my patients in Kingston, who was basically a throwaway patient. She'd been to every doctor around, and she'd actually moved from Kingston to Toronto. And then as she was in her 50s, she had nowhere to turn to, so she came back home. But she was treated like a pariah because she came from a prominent family. And once she started to get better, I asked her, so what is it that you want to do in life? And it was more a positive liberty question. And she said, I want to be an author. So that was around the year 2000. So I said, okay, have you started journaling? He said a little bit. She said a little bit. So I said, okay, let's see if that is going to be the seeds of what your book is going to be about. And it took 7 years, but that book was published. And that book is called Facing Life by Nancy Brown. And she went on to write another book, which was published in 2011 called Transcending the Legacy, which is largely about snippets of all the trauma she went through. So people are amazing once we know how to open the doors. So
Yeah, I think
but
that connection between a person's spiritual beliefs, their beliefs about themselves, their value, the world,
exactly.
their lovability is intimately connected to early experiences.
Yeah. And one other thing that hasn't come up yet, and I didn't specifically mention, going from the perspective of emotions, we talk a lot about fear, anger, and shame. So fear connected with anxiety, anger connected with day-to-day stress, all the resentments are talked about in recovery circles. And shame is the most deep-rooted emotion that carries so much baggage from the past. And from that perspective, we even talk about colloquially of the disease, the brain disease, being a shame generator. And that's where the scientific mechanism I can't define for you, but I can share tons of clinical experience and personal experience from people with addiction. This is a point they connect with, that they experience shame for no reason, which colloquially in our society is often referred to as the imposter syndrome. So it's not imposter syndrome necessarily, although if someone likes that term, they may use it, but it's important to get underneath that, which is shame, and recognize when the disease generates shame. And that's been one of the strengths of 12-step peer support programs, that people then see it's a level playing field. What one is experiencing, someone else is experiencing. And the brain is just giving people misinformation. And once they are able to provide someone with that feedback that, no, you are a capable individual, so whatever your brain is telling you is not valid, then they're able to hear it from the other person too. And then I
So
call that mutual spiritual growth.
I see that Tom has posed a question
Okay.
specifically about shame. What is the best method of intervening with shame and techniques?
Yeah, shame is first step is to acknowledge it. Because I have so many patients who say, no, I'm such a successful person, I have no shame. It's only when we start to draw back the curtains and say, okay, what is driving you towards achievement? So sometimes it comes up as, oh, I want to prove to everyone else how much better I am than everyone else. So that's actually a shame-driven behavior. Even pride, people talk about, I'm proud of this, I'm proud of that, I'm proud of my son, or I'm proud of my daughter. So we start that dialogue that if your daughter or your son didn't achieve that, what would you feel about them? Oh, I would still love them. So then people start to see that using terms like pride and I'm proud of you actually reinforce trying to hide shame or overcome shame a little bit dysfunctionally. The way we do it and talk about it is to encourage releasing shame. To the extent that a senior colleague, Kim, you may remember Dr. Stan Gitlow, who is the father of Stu Gitlow, who's still around in ASAM. So Stan was an internist, addictionist, and he used to say that shame is an obligate anaerobe. So from a technical perspective, an obligate anaerobe means that it's an organism that only survives in the dark in an environment where there's no oxygen. So his encouragement was, which I still follow, is to out the shame, to release it into the air where there's oxygen and release it into the light where you can share it openly with other people. And that's where, if Tom, you haven't been to 12-step meetings, I would encourage you to strongly go, because that's where you can see in action as to what releasing shame looks like. And we try and do that at HUM in group psychotherapy sessions and in individual sessions. So I hope that helps.
Yeah. And I see that Therese Kylene, who's a prominent addiction researcher in the US, has unmuted. Therese, if you have a question, please feel free to ask.
Oh, can you hear me?
Yep.
Yes, please.
Oh, yeah. Okay. So, yeah, I certainly feel that, think that AA is an incredibly powerful tool. In the US, we have a lot of patients that do not really value AA or really don't use it. We have a lot of evidence-based treatments, and I know from ASAM, you probably know about these. In particular, I see a lot of, or I've dealt with a lot of PTSD, substance use disorder, in both veterans and civilian PTSD and substance use disorder. And we've developed a number of integrated treatments for both of these disorders. Kind of the evidence base for substance use disorder and PTSD, which we know PE and prolonged exposure, processing therapy, which of course both of these will deal with a lot of the shame, guilt, and anger that is associated with both PTSD and substance use disorder. So just wanted to get your opinion on some of the other treatments that we have.
Yeah, my reflection back would be any and all. My push is usually to remember the framework of addiction and the framework of other diagnoses and how they interrelate.
Right.
Because when we are talking to a patient, they're just one person. And sometimes care providers, we don't have enough unity amongst ourselves. And as I'm answering your comments, I'm reminded of a patient who came to see me a few years ago who was on multiple psychotropic medications because he had carried a bipolar disorder diagnosis for almost 20 years. Mm-hmm. And he saw a new psychiatrist who said, no, you don't have bipolar disorder, you have borderline personality disorder. So you go off all these medications, they're not doing you any good. And he said, yeah, these medications weren't really doing me any good. So it was very confusing for this individual. So we sat down, and I didn't dispute the borderline personality disorder diagnosis, but as Dr. Kim was mentioning, I did a workshop at the International Society of Addiction Medicine in Istanbul just this fall, which was on borderline personality disorder in the context of addiction involving relationships. So once this person understood the addiction framework, then he could see what was labeled as manic episode or what was labeled as depression, and that this psychiatrist didn't see it as another psychiatrist may have seen it. He started to see, okay, now I can look at it, how it manifests in my life. Now, this particular patient also has a lot of chronic pain. So he's someone who's still on medication, but his medication regimen now is much simpler than what he came on initially. And he's happy with an addiction diagnosis, a chronic pain diagnosis. And we don't talk much about borderline personality disorder because it's all in the context of addiction. Now, in his particular case, he's off opioids even in dealing with his chronic pain. And he's still using a little bit of cannabis, but it's all in the context of harm reduction. His life is completely different than what it was 4 years ago when he first came.
Right. Yeah, I totally agree. There's so many individual needs.
Yeah.
And we do have a lot of great treatments.
Yeah. And this particular individual also never connected with 12-step programs, and his problems are so complicated that he doesn't trust people to be able to talk to them about his problems. So what he's developed is actually his own circle in his community that he meets with once a week, and he feels safe there. He did go through our intensive outpatient program, so he really appreciated group psychotherapy, but he lives a little bit outside of Calgary, so it's not so easy for him to come to our weekly group psychotherapy, and he's stable enough that he's doing fine, but he knows the option is there that if things destabilize, then he trusts that he'll come and join one of our groups and come every week. So that's the other benefit that longitudinal care offers, and I'm grateful that I'm able to provide that, and our system in Canada provides that opportunity for physicians, is to be available and increase the intensity of care when something flares up, and then dial it down as people stabilize, and we meet them where they're at, and we can make the suggestions, but different people will do different things.
Thank you.
Thank you, Therese. I have a question about, again, like the difference, I think, between DSM-5, even ICD-11, which sort of makes the way that it's even said, makes people think like the substance is what's causing the disorder. Yeah. I treat a lot of patients with eating disorders, and some of the research that we're doing here at SunCloud looks at food addiction as part of eating disorders, and in patients who don't have eating disorders. And it's a controversial concept, right? So I was interested to know sort of your thoughts, if any, on food addiction as a clinical entity.
Absolutely. And actually, because the definition is addiction, and one thing when this question comes up is I always take people back to the question of why do we have a reward circuitry in our brain? And I'll give you a moment to ponder and then answer in the interest of time, that we have a reward circuitry because we need to be able to have reward from food, which is important for individual survival, and have reward from sex, which is important for species survival. So regardless of how addiction manifests outside, every single patient with addiction has reinforcement from food. Now, an overt severe eating disorder may or may not manifest in an individual. And if it does, then we have to use strategies that address that aspect. But I end up talking about addiction involving food with every patient. And same thing with addiction involving sex, love, and relationships. So, in Calgary especially, the Sex and Love Addicts Anonymous community has become quite strong over the last 10 years. And I ran into someone actually in my building parking lot, and he was looking for direction, and just to make a long story short, I invited him to sit in my car and I said, I'll drop you off. You can just go from there. It was only a few hundred meters away from here. So then he started chatting, like, what do you do? So I told him. So he says, oh, so you're Dr. Hajela? I said, yes. He says, I've been going to SLAA for 5 years. And he says, thank you. So I said, what do you mean? He says, I know that it was because of you that SLAA got established in Calgary. And man says, yes, and it is true. And it is odd that as a city as big as Calgary didn't have Sex and Love Addicts Anonymous. Largely, I know from talking to my colleagues too, the thinking in the psychiatric physician community here was, no, that's a problem that's in other communities, not here. So I think a lot of that happens, that we need to dispel these notions and say, no, this is what the actual circuitry is. This is what the fundamental problem is and how it manifests. Then we have to individualize the treatment.
Yeah,
and
or even
from what Therese was saying, and you said that there's a tendency, which is true, that substances make the disease of addiction worse, but substances don't cause the disease of addiction. So those are important points to remember.
Yeah, well, and there's still a lot of, at least in psychiatric circles in the US, sex addiction isn't really
not recognized.
thing.
Yeah.
Like that can't be a thing because, it's
Despite
a
the
necessary part of procreation or whatever.
Exactly. But if you look at DSM, sexual disorder, NOS, not otherwise specified, has been part of DSM right from the beginning. So there's a lot of disconnect within the psychology and psychiatry community. So it's more political rather than based in science. Because even for NIDA, it's still called National Institute on Drug Abuse. And Nora Wolf, who was an acquaintance friend, we see each other only occasionally, but going back to 2016, she was very clear. She was trying to push the idea that NIDA needs to change its name from National Institute on Drug Abuse to National Institute on Diseases of Addiction. So even though the director of NIDA and many of the researchers hold a different point of view, but there is a government directive that says, no, they have to beat that drum that drugs cause addiction. So that idea, unfortunately, NIDA is not able to move from because of a political directive that in some ways goes back to Richard Nixon. And ONDCP still holds a lot of power over National Institutes of Health. Now, everybody in the audience is familiar with ONDCP, the Office of National Drug Control Policy that exists in the White House. And the person is appointed by the president, and that is the person known as the drug czar. Okay. I see another question here. How do you feel about vagal toning and somatic therapies? And the answer is yes, any or all of the above. It depends on where the person is at, what their belief systems are, and what they're willing to try. And that's why, for me, Ayurveda is something that I'm very adept in, making recommendations and assessing people on that framework. So especially people who go to yoga are being exposed to Ayurvedic ideas. So we try and include any or all of it. Someone who works with us who's not technically part of HUM, but she shares space with us. She's an energy worker, and she uses a technique called transformational breath, which is also very effective in emotional regulation. So all of these things that help the nervous system come to a better regulatory performance level, they're all helpful.
We are just about at the end of our time. We have 1 minute left. So I just want to thank you again, Dr. Hajela, for coming and sharing your expertise with us here today. I will remind everybody who has come to get your CE credit or CME credit. You'll be receiving an email later on today from Tammy Gezer through SunCloud Health with a link to fill out the post-event survey and a quick post-test, and that will direct you to your certificate. So thank you again for everybody for coming. This presentation has been recorded and will be posted on our website. So if you have colleagues that you think may benefit from listening to our discussion here today, they can find that under the continuing education button on our website, www.suncloudhealth.com. All right. Thank you again.
Thank you for inviting me, and thank you for everybody's participation.
Awesome. All right. Have a good Friday, everybody.
Yes.